Here to Dr. Spivey. We've got our Zoomers online, so we'll check the chat. Friends on Zoom, if you want to put questions in the chat, you can feel free to do that. And we will check that at the end of the presentation as well. And then we'll do announcements and introductions after Dr. Spivey's presentation. Thank you, everyone. Welcome.
Can you hear me on this? Hello? That's probably this one. All right. Can you hear that? Yep.
What?
There we go. We'll see if it's in the right spot, if I can continue to hear me. Okay, so yeah, I am Dr. Spivey. I'm a geriatrician. I grew up in Wyoming and subsequently came to Nebraska to do my medical school training in Creighton because all of my family lives in Nebraska. Then I went to residency and fellowship at the University of Utah and finished in 2014. And since then, I've been doing extensively geriatrics work. So I am an internist to begin with, and then a geriatrician. So I have pretty extensive experience dealing with a lot of people with complicated. You can? Let's see. Is that better? Maybe. Okay, I'll try and keep my head down a little bit. All right, so yeah, so I have pretty extensive experience with dealing with people of the older age group. I did a lot of primary care when I was at the VA in New Mexico. In Colorado, I worked as a skilled nursing. I did post-acute rehab for the PACE program there. And then since September of last year, I've been doing geriatrics with CHI. So what we're going to talk about today, if I can get my thing to work. Thanks, Carla. What we're going to talk about today is just kind of what is a geriatrician, or not super common, what to expect if you came to a geriatric visit, some tips on healthy aging, and some kind of background and tips on some of the common diseases that happen with aging. We'll talk a little bit about memory and cognition that can change with aging, and of course, a few tips for caregivers of people with dementia, which I'm sure in this group, Carla probably talks about the importance of taking care of yourself as a caregiver for Parkinson's as well. All right, so what do we treat? So I tend to focus on things that interfere with function. So I talk a lot when geriatricians see you about any changes that people may have in their activities of daily living. I talk a lot about falls. We deal with frailty, which is kind of a syndrome that makes you more prone to having kind of worsened outcomes and problems if you do get sick. Talk a lot about memory, dementia, delirium. And then a lot of things that are common with aging, maybe also common with Parkinson's disease, are things like constipation and mood problems. And also talk a little bit about arthritis and pain, because arthritis is very common in aging as well. So how am I different than a regular PCP? So some geriatricians are PCPs. I am actually a consultant. So the main thing, like I said, that makes us different from a regular doctor is that we really focus on function and optimizing your quality of life. We pay really close attention to falls, brain health. We work closely with the family and the community. We work on your advanced directives and goals of care. And the one thing that I like to tell people is that I really value having a good space for discussion. So my visits tend to be longer than most primary care and other specialists. My consults can be anywhere from 60 to 90 minutes, and my follow-ups tend to be 30 minutes unless there's something really, really fast that we're going to deal with, which, as you know, is fast doesn't always happen the way we think fast is going to be, right? So things to expect if you come to see me. So I will, of course, be asking you about your activities of daily living. Those you may be familiar with are the things that we do to kind of keep ourselves functioning and independent in life. Things like bathing, dressing, transferring, We call those ADLs, and there's instrumental ADLs, which we think of as things like driving, shopping, managing meds, things like that. I'll go through your medications very closely. One of the things that I think is really important and that can happen as we age is that doctors and providers kind of tend to throw more and more and more medications on, and sometimes they forget to take them off. So what I do in my visits is I really focus on, are these medications doing something helpful, or are they causing side effects? If they're not doing something helpful and they're causing side effects, we definitely should get rid of them. If they're not doing something helpful, we should probably get rid of those too, because there's no point in taking a medicine that's not helping, right? I will always do a fall evaluation, and I'll always talk about your mood. And if the situation is such that memory is a concern, then I'll follow up and do an evaluation for memory as well. We'll talk a lot about what are your overall goals of care individually, and the recommendations that will be made at the end of the visit will be based on those goals. Okay, so how to prepare for a visit with me. So like any provider, it's always good to bring a list of the questions that you have so that you don't forget them as you're going along. Bring an extra head with you, right? So I say 2 heads are better than 1. If you can bring somebody with you that can write notes and kind of keep you on track, that's going to be very helpful. Because I am so focused on medications, I really like if people bring every single medication that they have in their house to my visit, okay, including those things that are shoved under the cabinets that you only use a couple times a year, any supplements or over-the-counter things that you take. Just because you can buy it over the counter or at the drugstore doesn't mean that it's safe. There may still be some interactions with other medications, and so we want to make sure that we're looking for those things. Like your PCP, I'll have you bring in all of your information that you're gathering. So if you're gathering information for your blood pressure, if you're following your blood sugars for diabetes, that's going to be really helpful information for me as well. One of the things that we know is that people who are older have some increased risks with things like low blood sugars that are not such a big risk when you're in your 50s. People have an increased risk of having what we call orthostatic hypotension, which also happens in Parkinson's disease, where your blood pressure might seem like it's okay when you're sitting, but when you're standing, it's very low and can make you fall. And so if those are the cases, I want to see what your blood pressure and sugars are so that we can adjust those and make sure that you're being safe. Always bring anything that's normally used or recommended, right? So if you use a cane, please bring your cane. If you use hearing aids, please bring those. It's hard to talk to a doctor if you can't hear them. And then because we're going to be doing a walking evaluation and kind of a mobility, it's always good to bring kind of good walking shoes. Now we'll talk a little bit about some tips for healthy aging. The activities of daily living we kind of talked about, but these are super, super important to keep you independent and at home as long as possible, right? So you want to keep both your mind and your body busy. Staying fit is really important, and staying independent, right? So you have to be able to move, to be able to get around your house, to do the things that you need to do. It's good. I always want to encourage people to stay connected with friends and do supportive activities, things like playing cards, just going to family picnics and things like that. Very important. One way to kind of keep your mind limber that I talk about is taking a new class or learning a new thing. There is a program here in town, I don't know if everyone's familiar, called OLI, the Osher Lifelong Learning Institute, and it has some really great classes that I recommend if you're interested at all to look into them. It's not classes like you took in college or high school where you have to take a test afterwards. They're just classes on things that people find interesting. So some of the classes might be on World War II history, some of the classes might be common flowers and native shrubs that you find around the area, kayaking, how to change a bike tire, some pretty basic things that can be fun for people. And then, you know, in order to stay independent with your activities of daily living, if you are having some trouble and you aren't able to do things the way you did when you were in your 40s and 50s, then you probably would benefit from having a physical or occupational therapist kind of help you figure out what equipment might help you maintain those independence. All right. Off we go. Okay. So then I talk a lot about fall prevention. Again, exercise is very, very important in preventing falls. You want to keep your quads nice and strong so you can stand and sit appropriately. The best exercises for people to prevent falls are the ones that have both a strength as well as a balance component to them. So Tai Chi is actually a really great, well-studied intervention for people who are at high risk for falls, for preventing falls and limiting those. It really works on kind of these slow movements, which really helps your body stay balanced. I also really like it because mentally it can be very calming as well. It's a kind of a meditative practice. You kind of work your breathing along with your physical movements and can really help kind of clear the mind and stay calm. You can find a lot of classes at the senior centers, at assisted living, in the community. Just because it's in the community and it has a certain price linked to it, I would always recommend to call and see if maybe there's a senior discount or some other kind of intervention that they might have that's available for you. Again, if you're using assistive devices, please make sure that someone has actually evaluated them. A lot of people will use the walker that's in the garage from their ex-husband's cousin. And it may or may not be the right height, right? Or the right structure for you. So you want to make sure that a therapist is kind of given the blessing that, yes, this is the right fit for you. And then we want to make sure that it's kept up mechanically. Keeping your home clear and safe. So I'm sure you've talked a lot about throw rugs and things like that, using grab bars. Those things are really important to prevent falls. And then we'll just harp on the medications on every single slide. So medications can make you fall as well. So those are kind of some of those side effects that we want to make sure that we're getting rid of if possible. All right. Frailty is a syndrome. I kind of touched on this. This isn't something that you hear a lot by different doctors, I don't think. It's not necessarily like diabetes. You can't just hang your hat on it and call it something, but it is this syndrome that links all of these different things together, right? And together as a whole, it makes you at higher risk of having kind of poorer outcomes, longer hospitalizations, stay sicker longer. And it can be any kind of any pieces of this puzzle put together that kind of build into this. But we want to prevent it. Prevention is worth a pound of cure, right? So same things as fall prevention and others, keeping the ADLs. You want to keep active, functionally, physically, making sure that if you do have problems with your mood or your cognition, that you're getting treatment for those. And then the other thing is that we have over time something that's called sarcopenia. As we age, we tend to have more fat and less muscle. We lose muscle, and even if we're the same weights, the muscle to fat ratio kind of changes over time. So it's really, really important to get enough protein in your diet to kind of keep that healthy muscle where it needs to be. And ask about medications, of course. Okay. So brain health, so keeping your brain healthy and strong. So whatever is good for the heart is good for the brains, right? So if you're on medications that are for cardiovascular disease, you want to have all of those things well controlled. We want to exercise. We know that exercise is really good for the heart, keeps us strong and living longer. Same for the brain. Again, staying connected with friends and family, learning new languages, staying engaged in the things that you love, right? There's something very, very important in continuing to do the things that are important to you. All right, speaking about mental health, right? So depression and anxiety are very, very common as we age, just as common or more so than they are in younger adults. One of the things that you can do to kind of fight this is to kind of make sure that you're spending time outside. Being outside and in the real sun, being around nature is very good for your brain and for your mood. There's even something called light therapy that I recommend for some people, where you have this little lamp, kind of like is in the picture, and you shine it not directly in your face, because that's bright light in your face, but kind of on the side of your face. And it kind of, if you aren't able to get outside, it kind of mimics being outside in the real sunlight. And that helps people with their depression and their mood. Usually first thing in the morning, it kind of mimics the sun rising and just kind of getting that, and it's a good way to start the day. Of course, want to stay active and moving, do the interactions with friends. And then if you have, your spiritual health is just as important as everything else, particularly when we're talking about mental or cognitive issues. That's a very important part. So spirituality has been something that's important to you. Making sure there's a way to continue doing that is good. I know a lot of most churches, I would say, have some sort of layperson, if not the priest or the pastor, that can come to your house and give you communion or talk to you, even if you can't get to church on your own. All right, and then here, medications, again, we don't want medications that are causing side effects, but if you need medications for something, then this would be an appropriate time potentially to use. All right, so staying healthy includes not just your lower body, but also kind of up here in your head and neck, right? So staying on top of your vision. Vision loss has been associated with falls, so we want to keep that sharp. Hearing, so interestingly, people who have hearing problems seem like they have some cognitive difficulties even when they don't. But they can also worsen any cognitive difficulties that people do have over time, because they're just not getting the right stimulation and input that they should be getting in order to think and process as well as they can. And then dental health is very, very important, particularly thinking about anyone, but thinking about people who are in nursing homes and assisted livings, making sure that the staff is doing a good job, being sure that dentures are being washed, people's teeth are being brushed. The bacteria that grows on teeth can be very dangerous for different infections throughout the body, including pneumonias. People oftentimes will have an aspiration and a pneumonia, and if you aspirate clean saliva, it's not as big of a problem as if you aspirate bacteria-filled saliva if the teeth haven't been brushed. So make sure you go into the dentist regularly. Even people with dentures should be going to the dentist at least once a year, whether they think their dentures are fitting or not. Okay. Now we'll kind of talk about a little bit more specific parts of the body. So urinary tract health is something that I talk to people a lot about. Obviously, this looks different for men and women in some cases, not only because of the anatomy, but it just is the way that it is. So one of the things that causes a lot of incontinence or can worsen incontinence or urgency is that people are waiting too long to go to the bathroom. As we get older, we're not as fast. We're not able to walk as fast, and those with Parkinson's may know that this is kind of a problem as well. So oftentimes I'll tell people to schedule bathroom times, whether they feel like they need to go to the bathroom or not. Then you're just going. You're not waiting for your body to give you the urge and then trying to rush there to get there on time. Okay. Pelvic floor exercises. I think a lot of people think that these are only for women. But men can benefit from pelvic floor exercises as well. There's many physical therapists and occupational therapists in the town that can help with that. And something to be aware of, again, with medications, is that a lot of the medications that we use for incontinence can have pretty significant side effects. So one that's very common that's used is called oxybutynin or ditropan. It can cause people, it's an anticholinergic medication, and so it causes sometimes people to have a dry mouth. It can cause urinary retention, even though we're trying to treat urinary problems in itself, it can sometimes make those worse. It can make people feel dizzy. But the dry mouth, I think, is the worst thing that I hear complaints about all the time. And it doesn't really work that great, right? So in the studies, when they've looked at it, I don't know the exact numbers off the top of my head, but if someone was peeing like 20 times a day, it might bring it to 17 times a day. Well, if you're peeing that often, I don't know if an extra 3 times a day is really going to make that big a difference, okay? Some of the medications that are a little bit safer to use. So for women, there is topical estrogen that can be used to kind of keep the vaginal tissue healthy. Tamsulosin can be used for both men and women to help void, kind of relaxes the sphincter on the urethra and it lets people pee easier. And then for men, there's a medication called finasteride that's kind of a hormone blocker, and it basically shrinks the prostate over time. It's a very common medications with pretty few side effects. Something to be aware of if you do have frequent urinary tract infections or any urinary tract infections, that these do look a little bit different between men and women. And primarily because of the anatomy. If bacteria is able to get all the way into a man's bladder, then it's kind of done, it's gone farther than in getting into a woman's bladder, right? And so generally we consider those to be more serious infections and harder to treat. So it's important to know that if someone gives you 3 days of antibiotics, is pretty common length of time for women, men almost always need 7 days or more. Okay, and we always want to make sure that the bacteria is cultured to be sure that the antibiotic that's being used is actually killing the bug that's causing the problem. All right. So bowel health, again, something that's very, very common. People tend to have a lot of problems with constipation as we get older. Multiple reasons for this. One of them is that as we age, for whatever reason, we naturally stop feeling thirsty even when our body is dehydrated. This is part of why older people are at such high risk during heat waves, because even though their body would normally have signaled that they're thirsty when they were in their 40s, 50s, 60s, it's no longer doing that, right? We're not getting enough water. We tend to be more constipated. If people are more sedentary and not walking as much, we tend to be more constipated because that movement is actually really good to kind of help with the peristalsis or the movement in bowel, okay? So walking is very important. It's good to always be sure you're staying mobile. The other thing that can help with constipation is making sure that you get enough fiber. So the fiber that is important to get is not Benefiber or Metamucil. Those supplement fibers can actually sometimes cause the bowels to get really hard. Again, because oftentimes people are not drinking enough water. And so instead of helping, the bowels get really, really hard and can actually make things worse, even though that's what you're trying to help with. So you need to get fiber from foods, right? So you get the bulk along with the fiber to help. So prunes, a lot of people use prunes, which is fine. Oftentimes that's not quite enough, right? And then you may need to go to a medication to help. The thing to know is that the over-the-counter stool softeners, similarly, my colleague that used to teach me would say it gives you the mush without the push, right? You need to get things out, okay? So the stool softener is often not enough by itself either. You may need a laxative with it. So there's combination laxatives or Miralax, which you can all get with the purple cap, right? Don't confuse it with the fiber. It's a different thing. And that's a super, super safe medication that can be titrated up and down as needed. Funny story. My son, when he was about 6, saw his dad drinking some Miralax and decided that he was going to be cool and get some Miralax. And so he got a cup and filled it like this full of Miralax with just a little bit of water. And then he was up all night. My husband got to deal with it because I'm the stepmom, and it was newly after our marriage, so he got to address the Miralax overdose. But that's all that happens, right? If you overdose on Miralax, you just poop a lot. It's okay. All right, so let's talk a little bit about pain management, okay? Again, exercise and mobility are the keys. If you have arthritis in your knee, people tend to think that my knee is gonna get worse if I keep walking on it, right? But it's really important to strengthen the muscles above and below the knee to keep things stable and in the place where they need to be, staying limber. Tylenol is kind of the mainstay, safest medication to use. People tell me, well, someone told me that it will affect my kidneys. I think a lot of times people get it mixed up. Tylenol is not bad on the kidneys. Tylenol is very safe for the kidneys. In really high doses, Tylenol can be hard on the liver, but for most people, taking regular doses, that's not an issue, as long as you don't have cirrhosis or some other kind of disease, right? So Tylenol is a good, safe medication to start with for most people. Topical medications, I request people try those as much as possible, because you can use pretty much anything topically is not going to get into your body systemically and cause the same problems that pills might. So a little bit safer. So things like Voltaren is actually like ibuprofen, but in a gel, and it doesn't have the side effects of kind of ibuprofen does have. The side effect of having kidney problems, but the topical isn't at a strong enough level to do that. Also things like capsaicin or Bengay or lidocaine. We may kind of snicker that they're not the strongest things in the world, but they do help and they don't have a whole lot of side effects. And so if that's enough to get the job done, then that's great. As I mentioned, the ibuprofen and similar medications, we call them non-steroidal anti-inflammatories or NSAIDs. Those can cause problems with your GI tract and can cause heartburn and ulcers and kidney problems. And as we age, we get more and more sensitive to those things. People with heart failure, those can kind of trigger a heart failure exacerbation. So important to kind of stay away from those, lean more towards the Tylenol and the topicals. Obviously there's other things that can help, right? So physical therapy, chiropractors, acupuncture, newly, we were just talking, just now that there's some red light therapy that people can do that kind of helps. And a physician provider here in town, recently told me that he is doing a protocol with x-rays that has been really beneficial to people with just regular arthritis. Just very, very low dose x-rays, kind of decreases the inflammation and helps with pain. Narcotics, as you all probably are aware of, we're in a opioid endemic, right? So these have been unfortunately used, and I think everyone thought that they were doing a good job trying to make sure that we're treating pain, and then realized that these medications, don't really do a great job of treating pain long term, unless people have cancer or some other problems. And B, they have a lot of side effects, including the potential for abuse and dependence. So they should be used in certain situations, but judiciously, right? So we want to use the smallest dose we need for the shortest amount of time we need, but there is a place for them at times. Okay. A lot of people have trouble sleeping, right? And so this is a very common problem that I hear of with my patients with aging. Important things to know again, so medications, many of the medications have a lot of side effects, right? So they can make you feel drunk or dopey or hazy the next day. Some of the medications can give people hallucinations. There's stories of people on Ambien walking outside in the middle of their street with no clothes on because they think that they're doing things, or waking up and eating half of the refrigerator full of food, right? So they're not, seems kind of funny, but they are kind of dangerous, some of them. So the biggest thing to do, and they don't actually, the medications don't actually fix the problem, right, of sleeping poorly. They just kind of knock you out a little bit. And maybe there's a place for that for, again, a short time. But not generally long-term. Long-term, we want to focus on what's causing the problem in and of itself. So if the problem is that you're anxious and you just have your mind racing and racing at night, then probably we need to look at your mental health and make sure that your anxiety is being treated appropriately, any depression. And then make sure that we have a good sleep hygiene. And sleep hygiene, we talk about just having a pattern of at the same time every night going to bed and having kind of this pre-bedtime ritual that helps you kind of calm down, right? So watching the news on the war on Ukraine and Palestine is probably not going to help you calm down and go to sleep, right? So turning the TV off a couple of hours before you go to bed, keeping the rooms dim as you're trying to relax for the night, maybe drinking some tea, putting some lotion on your hands, all of those things to kind of prepare you. And then when you go to bed, you use the bed for, you say you use the bed as for sleep and sex. It is not for watching videos or playing on your iPhone or texting people. Really kind of maintaining that will help you once your body kind of say, okay, I'm in bed, it's time to sleep. Okay. Melatonin, on the other hand, is very safe medication in low doses, usually not more than 3 to 5 milligrams. It's a natural hormone that your body makes, and what it does is it helps to regulate the circadian rhythm. And so if you take it at the same time every night, it's part of that kind of sleep hygiene. It teaches your body that, oh, this is nighttime. So the melatonin kicks in, you have a higher melatonin at nighttime, it makes you more tired. It doesn't work like right away, right? So people will say, oh, I sometimes take melatonin and it helps. That maybe a little bit, but it may be what we call the placebo effects, that people are kind of feeling like it's helping and then it does. It's more of a medication that over time kind of helps with the regulation. And then light therapy, like mood, it can actually be helpful for sleep as well. Kind of that bright light being, keeping us really awake during the day and less drowsy during the day helps us sleep better. Okay, Carla asked me to kind of mention advanced directives briefly. So one of the things that I talk to people about is that advanced directives are great. Everyone should fill them out, but the most important thing you can do is to make sure that your power of attorney is identified, right? And the second most important thing you can do is make sure that your power of attorney knows what it is that you want. So a lot of people will say, oh, my cousin's my power of attorney. Well, do they know that you wouldn't want to be on dialysis, or do they know that you would want only to be on a life support for 3 days or less? You know, those kinds of discussions are really important to have. Oftentimes it's a family member like your daughter or your son or your husband, and they know you very well, and it's not necessarily a huge thing, but making sure that they know who they are and you know who they are. And then kind of recognizing that there are two different powers of attorney, right? So there's the financial power of attorney, which thankfully I have little to nothing to do with because money is not my thing. And then there's the medical power of attorney. Those can be the same person. They're not necessarily the same person. Your power of attorney is there in case you can't make decisions, right? So your daughter or son or whoever is your power of attorney should not just be making all of your decisions for you right now, unless you're not able to do so yourself, right? I have a lot of people come to say to me, well, I'm my mom's power of attorney. Well, that's great, but she is still driving and writing checks and doing all of her regular things. You can't override that, right? So that's an important thing to be aware of. Only if you've lost capacity or if you're really sick and you can't make decisions, that's when the power of attorney is actually invoked. People with dementia too, generally they need to have their power of attorney invoked by someone, and that's something that I could do, or other providers can do, neuropsychologists can do. In Nebraska, the MDPOA and POAs, they need to be notarized. So those papers need to be notarized in order to be acknowledged and approved. In some of the states that I worked in, the medical power of attorney didn't necessarily need to be. It would just be, I was a doctor, so I could write, this is what they said their medical power of attorney. But here in Nebraska, you have to go get it notarized. So it's something that's. And then if you need something to kind of help you guide you through some of those conversations with your loved one, there are things called the 5 wishes, and then different medical providers or social workers can also help you kind of clarify those goals and have those discussions for moving forward. Okay, So getting towards the end here, just kind of talk briefly about memory with aging. Okay, so there is some changes in memory that can happen with aging. Even with normal aging, there can be some memory changes. Those changes tend to be that it may take a little bit longer to find the right word. It may take 3 repetitions of a new name to remember somebody's name rather than 1 or 2 when you were younger. But overall, your function is normal. You're still able to pay your bills and rent and do your medications, and you can learn the new information. It just may take you a little bit longer. Okay, your scores on any kind of cognitive testing will be normal in normal aging. Okay, every function is fine. Something that starts to be a little pathological is something we call mild cognitive impairment. So a little more similar to normal aging because again, your function is still preserved. However, on the cognitive test, you may get a little bit lower on a cognitive test, and it may be that your family or your loved ones are saying, oh, I've noticed that you're having a little bit of trouble remembering things, or you may forget things more so. So the thing that helps if there is some mild cognitive impairment is keeping lists or writing down steps to do something that can kind of help you keep on track, even if you do have some mild cognitive impairment. Mild cognitive impairment does not mean that you will develop dementia. Okay, so people with mild cognitive impairment are at risk of developing dementia. About 10% per year might develop dementia with this. And I tell people that means 90% per year do not. Okay, so I know it's a possibility and it's definitely a real possibility, but it's not the scariest and worst thing in the world. Okay. Dementia, on the other hand, this is definitely not a normal part of aging. And the big difference with dementia, of course, is that more people are going to be noticing these problems with memory. The testing is going to show definitely a deficit in your ability to function cognitively, do test scores. But the big thing is that the daily function is affected, right? And you may have friends or family that have had this happen to them. Oftentimes, some of the first clues that somebody has dementia is that they're making mistakes with their medications or getting confused or missing their gas bill or payments, or they're having their utilities shut off because of things like that. So if you're noticing people having those things, it may be time to kind of be a little bit concerned and maybe come in and have an evaluation done. And again, the thing that's the worst maybe about dementia is it oftentimes interferes with people's ability to stay independent and live independent. So you want to get as much help as early. So this kind of talks a little bit about aging, the way that I just talked about it. Okay, so this little blue dotted line here would be your function. So that's your function is normal. So there's very few people that are up there that do super aging, so they don't have any really kind of mental or cognitive decline whatsoever, right? More normal is that green line. You might have a little bit of decrease in your quickness of answering things and learning, but you're still doing all your daily functions. Mild cognitive impairment's a little bit more, and then dementia even more so. Okay, so who can do the evaluation of memory and cognition, right? So sometimes primary care doctors can do this. It's kind of variable. Some people are very comfortable with it, some people are not. So it's not necessarily a guarantee that they're going to be able to do that well. Geriatricians and neuropsychologists are probably what you would consider to be the experts in the field. I guess neurologists should probably be up there as well. Geriatricians and neurologists, so their testing that they do in the office usually takes about 15 to 20 minutes. It's a shorter test, 1 page, kind of gets an idea of where you are, kind of tell, does this person have dementia or not? A neuropsychologist is a person with a PhD in psychology, and so they don't do prescribing or anything. Their testing is very accurate, but it can take usually no less than 4 hours and anywhere up to 8 to multiple days going and doing testing, which can be kind of exhausting for a while. Important to kind of be aware that documentation and diagnosis of any kind of dementia or difficulties in your function are very important in activating any kind of life insurance, long-term health insurance that you might have. So that can help if you are in a situation where you need a little bit more assistance and you need that insurance act. All right. Got a little bit more. Should I go, or are you guys ready to stop for questions? Blacking out. Nobody's asleep yet. Okay. Very good. Okay, so some of the cognitive and non-cognitive things with dementia, right? So you're probably pretty familiar with the cognitive things. So there's this forgetfulness. A lot of people will come in and say, well, my mom can't have dementia because she remembers everything that happened when she was a kid. Okay, so that's great, but the forgetfulness with dementia is really short term. So it's now and slowly gets worse going backwards. So people will oftentimes have very, very intact memories of their younger years, which is why one of the things that we do for people with dementia, if they're having problems with aggression or behavior or mood, is that we bring their past familiar lives to them, and things like the music that they listened to when they were in their 20s and 30s and things like that, right? Because that further memory is still pretty intact. The recent memory is the stuff. So if you ask them, you know, what movie did you go to last night with your son? They might not even remember that they went to a movie, much less what the movie was, right? Or what was your breakfast today? No idea, right? You tell them 3 times we're gonna go to the mall, and they'll ask me, what are you doing today? And that's more of a dementia process, right? People can have trouble finding words, repeating questions. Some of the more distressing things that happen in dementia are something we call neuropsychiatric symptoms, okay? And those happen usually a little bit later in the stages of dementia. Things like pacing, hoarding, being aggressive, having some disinhibition can be really distressing to families, right? If you have your loved one and they don't realize that they're at a funeral and they're telling jokes, right? Or if they're at church and they're laughing really loud during the prayer. So that can be really, you know, and it's hard on families when this stuff happens, right? And so it's important to kind of have some tools on how to get around that. Again, sleep pattern changes can be very common, even more so in people with normal aging. And then something to be aware of just with dementia in general. People tend to be less hungry, and as dementia progresses to the end, they may not even want to eat at all, right? So that's not an abnormal thing. It's not something that you have to like insist that they eat. What we recommend for that is offering people the food that they like and giving it to them, offering it to them. If they don't want to eat, then that's their choice. Okay, so how do we kind of maximize function in dementia if people do have these things, right? So the biggest thing is to kind of keep things structured, kind of keep things in a routine. We all do better. I do better when my kids are in school, right? Because they leave. But also because there's a routine, right? They do better because there's a routine and they know what to expect, and their pattern gets better, their chores get done better, even though they had plenty of time in the summer to do their chores. Now they're in a routine, right? And so it works better. Avoiding over and under stimulation, right? So it may be, for some people, this can vary. How much is too much stimulation, how much is not? But generally, like going into a really crowded mall or bar or something like that, that may be too much for the person with dementia. Whereas just kind of leaving them at home or in the other room and not doing anything is probably understimulating, right? There needs to be something that people can do to kind of stay productive and feel like they're contributing to life and again, staying active and moving, keeping people healthy and exercising is good. Going for walks, going outside, very important. Give people the right amount of help progressively, right? So a lot of people, you know, so taking medications, for example, right? So people with early stage dementia may forget to take their medications, and they may have been taking them out of the pill box. And so it may be time to get them a pill box that's an organizer. And so then you just have to say, okay, mom, remember to take your pills with breakfast. And that may be enough, right? And then things may get to this as their dementia advances. Now, maybe the pill box in front of the breakfast doesn't trigger them to remember the pills. And so you may have to tell her, hey, mom, take your pills. And maybe they need a cue, right? As the dementia gets even farther, even that might not be enough. You might have to take them in her hand and put her in your hands in order for him to do it, right? The thing is that you don't want to do putting it in her hand before you need to, right? Because that can be demeaning to the person, right? So we want to keep people as independent as they can be, or as long as they can be. So kind of graduating how much assistance people need, because you also want to keep people independent and doing their daily functions as long as possible. Okay. Communicating well, so smiling, right? Everybody does better if we smile at them and are nice. Giving just one or two questions, particularly as dementia goes along, people can't really say, hey, George, go into the bedroom, take a shower, come back with, you know, your brown socks because we're going to church today or whatever. That may be too much. So just saying, you know, why don't you go take a shower? And then after the shower is done, here are your clothes, right? Or with choices, kind of saying, instead of saying, what do you want for breakfast today? That may be too open-ended, right? There's lots of different things a person might, their brain just might not be able to handle that, but instead giving a choice, you want oatmeal or eggs, right? And those are very simple choices that they can pick, and then it's a choice that they're able to. Using simple sentences, staying active with the things that they enjoy, right? So they may not be able to go fishing and boating anymore, but they can certainly look at a magazine of fishing and boating, and that could be very meaningful. Okay, again, so I tell people, anybody who has a damaged brain in any sort of way, from a head injury, from dementia, from anything else, it means that in order to stay at their normal function, their brain is working 3 times as hard as any of you or I's brain is, right? And so their brain is sensitive to anything else that can change. So if medications are going to be hard on me, they're going to be 3 times as hard on somebody with dementia. So it's even more critical to make sure that medications are being used appropriately and that these general health maintenance is being done and stayed on top of. Okay, last there is this thing we call delirium. Delirium is not dementia, it's something that happens very quick. But it does happen more often in dementia, like I said, because their brain is already working too hard. And so now they get sick, they get a urinary tract infection, and then they're just completely confused, right? Way more confused than they were before. So that is a real big sign. When people get delirium, oftentimes it means they're medically sick, not that they've gone crazy, right? So it's an important time to consider being evaluated by a medical professional. All right, and the biggest thing for delirium is preventing it, especially when you're in the hospital, making sure that people have all of their glasses, hearing aids, staying hydrated, all of those sorts of things. Much easier to prevent it than to treat it once it's there. All right, well, my PC is running low. Very good. I'm almost done. So for caregivers, really the biggest thing is to take care of yourself, right? You can't pour from an empty cup. So making sure that you're taking breaks. Make sure you're giving yourself grace. Nobody is perfect at this. It's a tough job. Ask for help and accept help when you need it, and maybe 3 steps before you think you need it. Because when you think you need it, probably your daughter or your son is saying, wow, you probably should have taken a break a month ago, because now you're just overwhelmed and exhausted, right? So being sure that you have support and people that love you in your life as well. Okay, take a break if you need it. And then looking into kind of some respite resources, which we have several around town, and I'm sure Carla has tons, and she has respite here that you could look into. Okay, I have just a few resources here that I'll leave up here in a little bit if you guys want to write any of these down, some different resources. But like I said, with the respite, so Home and Care Partners has this. Messiah has respite through Alta, through the Aging Partners is a place that you can look. to kind of find some support. St. Mark's has a respite group. So all sorts of different places that you can look, all right? It may seem like they're hard to find, but they're good. Okay, just look for them and ask if you need help finding them. And then the last thing here is just my contact information. If anybody wants to come see me, I'm at two places. I'm at East Lincoln Internal Medicine on 70th and Pioneer, and I'm also on 40th and Yankee Hill. So I would be happy to see whoever, covered by all insurance, Medicare, Medicaid. And happy to see anybody. You can refer yourself. You can have your provider refer you. Go back to the slide with all the resources. Can you go back one more, Carla? People want it. There you go. Okay. And then, does anyone have any questions? Yes.
Let them know about the.
Oh, yes. I also have some business cards over here. If anybody wants to grab one, it has my contact information if you need to get a hold of me or schedule an appointment. Yeah. Do you have a question?
Yes. Dementia and Parkinson's seem very similar. It seems fairly similar. Sometimes they close, which is one is the risk of Parkinson's has dementia.
Yeah, so that's a great question. So this gentleman said that dementia is very common in Parkinson's disease, and it seems very similar. Yeah, so generally when we talk about dementia, we're kind of talking about Alzheimer's dementia. That's the most common one. I consider dementia to be cats or dogs, right? So let's say they're dogs, right? So dementia is dogs. Alzheimer's disease might be a Labrador Retriever. Lewy body disease might be a Chihuahua. Parkinson's dementia might be an Irish setter, right? So they're all dementia, but they're just different types of dementia, right? So Parkinson's disease dementia only happens with people with Parkinson's disease. There's a similar dementia called Lewy body dementia, where the dementia comes first and the Parkinson's stuff comes second. In Parkinson's dementia, the Parkinson's comes first and the dementia comes second. Unfortunately, age is kind of the highest risk factor of dementia in general, and duration of Parkinson's is the most high risk factor for Parkinson's dementia, right? So yes, I don't know the exact numbers off the top of my head, but if you've had Parkinson's disease for 10 or more years, you're pretty high risk of developing dementia related to it. And so trying to plan ahead is very important for those things.
Another question.
Uh-huh.
You had Parkinson's for many years.
Mm-hmm.
It's away in your death, but it necessarily can progress fast.
If you have Parkinson's disease, is that what's going to cause your death? Is that what you're asking?
You know, partly is the fact that I've got 25 years of Parkinson's, relatively no symptoms.
Oh, okay. Yeah. Yeah, that's interesting. So he's asking, if you've had Parkinson's disease for many years, does that mean that you're going to die of the Parkinson's disease? And if you've had Parkinson's disease for 25 years and you're not having a lot of symptoms, are you going to progress with your Parkinson's disease? So those are also really good questions there. It's kind of hard to say. So particularly as Parkinson's disease gets very advanced. So people who have tons of symptoms of Parkinson's disease are obviously much more likely to die of complications of Parkinson's disease than those who don't. People with Parkinson's disease obviously can have all sorts of other problems, right? They can die in car accidents, just like me. They can have heart attacks, just like anybody else. So a lot of people with Parkinson's may not necessarily die from the Parkinson's itself. A lot of people who die from Parkinson's at the end are often people who have Parkinson's dementia and oftentimes have trouble swallowing and eating. And sometimes those people will have those aspiration events that oftentimes can kind of be a life-ending situation. So it just kind of depends on the person. I don't know that we know how to predict who's going to die from Parkinson's and who's going to die from other causes. In terms of if you have slowly progressive symptoms with your Parkinson's and you have pretty mild symptoms, are they going to get worse or not? So kind of like I was saying with the damaged brain, you're just at higher risk, right? And so what we would say is because you have Parkinson's disease, you probably have a little less reserve than what somebody without Parkinson's disease. And so you may not have progression of your symptoms, and it may just continue the same trajectory forever and maybe not change a whole lot. But it may be that if you were to get like a really bad infection or be in the hospital, then maybe your Parkinson's symptoms would suddenly get much worse. Again, it's highly variable from one person to the next.
Question.
Yes, ma'am.
I have an upcoming surgery.
Mhm.
Here. Yeah. We're gonna replace. I have an upcoming surgery, shoulder. Is there anything I need to be aware of?
Yes, so if you're preparing for kind of an elective surgery, for your shoulder, so probably you'll have to have a pre-op from your primary care. I would ask them, based on what specific medications you're on, which medications to be kind of cautious with after surgery and before surgery. One of the things, that's just important in general is just staying really well hydrated before and after the surgery. Knowing too, that if you're taking pain medications afterwards, you'll probably have some narcotics to take. You may need, so the narcotics will slow your bowel down, and so you may want to empirically start a stool softener or a laxative before it becomes a problem. Yes.
Is there a problem with having a bit of dementia in anesthetic, a general? And what would the outcome be?
Yeah, so again, he's asking if having dementia makes it riskier to have general anesthesia. I would say yes, in general. There's a higher risk of people having adverse outcomes from that. The thing of it is that you're getting these very powerful medications that put you to sleep, right? And so the metabolism of those drugs can take a little bit longer as we age. And again, those drugs are all centrally acting, so they're all in our brains and nerves and things like that. And the people with dementia, that's the problem with your brains and your nerves. And so if you're giving a really powerful medicine to something that's already damaged, some people just don't come back all the way. Sometimes they'll say, so I hear a lot of people say my mom and dad were fine, and then they got sick and they had their heart surgery and now they have bad dementia, right? So it's probably that mom and dad had a little bit of dementia before that nobody recognized. And then that anesthesia and that surgery made it a lot worse. So generally I don't recommend people who have dementia to have elective surgeries. Sometimes surgery is there, but then I would be even more cautious than I would in somebody else, making sure that there are other medications, that they're not taking a lot of other medications that might make them confused. I would be really, really cautious about trying to prevent delirium, right? So making sure that they have all their assisted devices, that you're telling them the day, that they're staying very oriented, staying very hydrated, to kind of minimize that as best you can, but yeah.
So do you think having shoulder surgery is elective or?
I would call shoulder surgery elective, yes, because you're not gonna die if you don't have the surgery. They feel like you're gonna die, right? And that's where everybody has to kind of come up with that risk and benefit themselves, right? Is my life worth living with the shoulder, or will I have a little more function with the shoulder? And everybody has to kind of decide, you know, where that is. Some people will have worse time with anesthesia, some people won't. It's hard to say. Anyone else? Anyone online have any questions?
Apparently not.
All right, very good. Well, thanks so much for having me. I appreciate it. You guys have a good one.
Wonderful day. Appreciate you. Let's thank her again. Quite a bit of, good information for us all. Now, she probably doesn't want to stay for announcements in our separation group, so we have to go first. I want to welcome everyone here today. Do we have new people? We do. Welcome are back here.
My name is Scott Beasley.
I'm back. I think we've got a family over here. I saw them come in.
My name is Heather, this is my daughter Alicia, my sister Robin, and we are here with my mother Becky.
Welcome, welcome. Are you from Lincoln? Good. Okay, I see some hands over here.
My name is Jerry Easley. And I live in the house.
Welcome. You're going to join.
I'm Jenny's other half, Carol.
Welcome, Carol. Any others?
I'm Rachel Kornfeld Lambrecht, and I'm friends with Nancy, but I'm really here primarily because I'm the caregiver for.
Okay. We hope all of you will come back. Oh, they're just coming.
I'm Carolyn Randall, and I'm here as a caregiver for my husband Jim, who has Parkinson's.
Did I miss anyone else? I'm good at that. Okay, a couple of announcements. The Davis Finney Foundation has some wonderful literature. They're called Every Victory Count books, and also a second book called Care Partner. And they are available. You can go on site to the Davis Finney Foundation and you can get it digitally. I think we have one over on the library table. I've also got a few at home, so if you let me know before you leave, I could get them to you if you would like to have them. I was just reading the other day, I thought this was exciting news, that Michael J. Fox Foundation, there's a lot of promise and momentum in drug development. And they listed about 4 different things that are up and coming, and they sound there's some are infusions and some are pills. So I have the article here if anybody, I'll put it on the library table if anyone wants to take a look at it. Also, we should be getting soon the registration forms for the UNMC meeting. Their symposium, the yearly symposium, it's on November 13th at the Embassy Suites in La Vista. So, pardon me?
I understand.
The UNMC has a symposium once a year, and it's going to be on November 13th at Embassy Suites in La Vista. And the last information I got said that we will register in the fall, and I think September might be the fall. Yeah. But we'll just have that because we don't have any control over when they're going to send the registration forms. But it's always a very positive meeting and educational and very helpful. So if you've been before, you probably will agree with me. If you haven't been, I would encourage you to consider participating. Any other announcements? anyone learned anything they want to share? Okay, there was any hands. Our next meeting will be September 22nd, and Mackenzie Marr will be with us, and she's going to talk about Medicare annual wellness. Maybe some of you have already been exposed to that, but it will be an educational thing for sure. I wanted to thank Gunter and Sally and Jim. Jim, raise your hand. Over by Jim is a table with the library's information. And Jim is Sally. Sally here, Jim belongs to Sally. And he brought the water. And so if you're really thirsty, thank him. The next thing we'll do is divide into two groups. Those with Parkinson's will stay in here. Those care partners will go into the kitchen. There's no food in the kitchen for you, so if you want some food, you gotta get it before you go. And there's a few cookies on the table. Anything else we need to discuss? Questions, concerns? Okay, well, we'll divide up into our two groups. Thanks for coming.